Good afternoon. It's already 2 o'clock. We'll start our pep talk. I'd like to welcome everybody to this pep talk. Please mute yourself, but always show your video picture. Sign in your name, Facebook account, or email address in the chat box. Please include names of companions attending. Use the chat box to ask questions and make comments while the pep talk is on. There will be group pictures at the start and end of the pep talk. As a reminder also, please take the online Learning Kung evaluation test exercise for mastery of learning and have a perfect score to get a certificate of commitment and accomplishment as shown below. The link has been placed in the chat box by Abet. Also, another reminder is for every 50 OLETE certificates, you are entitled to 1 voucher for free ROJoson telemedical consultation. So let's now have a group picture taking before we start the pep talk proper in 2 minutes. Please turn on your video. Okay. Okay. Please turn on your video. So okay. 1, 2, 3. Okay. Okay. So let's start. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. There are 3 courses in the PEP Talk. I completed the core course on October 9, 2021. And starting October 23, 2021 onwards, I have been tackling health disorder and health issue courses. This may take 3 years or longer depending on the enthusiasm of the participants. My pep talk today is entitled Fundamentals and Generalities in the Medical Management of Abdominal Disorders, an overview, as this is a big topic. This is part of the health disorder course. The empowerment objective is for the lay people to have an understanding of the generalities and fundamentals, the medical management of abdominal disorders. As I said, we will just focus on the overview of abdominal disorders for today. There will be several modules in this course. Abdominal disorders, which will be taken up today, abdominal pain, abdominal mass, abdominal obstruction, abdominal bleeding, jaundice, gallbladder disorder, hemorrhoids, abdominal hernias. So for today, we will just have an overview to start the ball rolling for this particular course. It's a big course, but it is an important course because this is a common problem among people, okay? Not only in the Philippines, but all over the world. Okay? What is an abdominal disorder? What are the different types of abdominal disorders? What are the causes? How common? clinical diagnosis of abdominal disorders, paraclinical diagnostic procedures for abdominal disorders, and basic treatment modalities for abdominal disorders. Definition of terms in the title of my pep talk and the limitation of the coverage. I will be using the word fundamentals to mean the simplest and essential facts and theories which can serve as a basis or foundation and support for advanced information. I will be using the word generalities to mean general statements of information, not covering specifics and details. And lastly, medical management to mean diagnosis and treatment usually done by physicians. So let's start with the first topic. What is an abdominal disorder? First, the meaning of the word disorder. Disorder is defined as a definite disruption to regular or normal bodily structure and functions, but the specific cause is not yet determined. So once identified, the specific cause is called the disease. So that's the difference between disorder and disease. Disease is more specific than disorder. Second, the meaning of the word abdomen in the title, abdominal disorder. Simply said, abdomen in layman's term is the belly. It has the abdominal wall. Here, abdominal wall, and within it is the abdominal cavity or the space, body space. So the belly or abdomen is below the thorax or the chest, and the diaphragm forms the upper surface of the abdominal cavity. So this separates the abdominal cavity from the chest cavity, the diaphragm. In the abdominal cavity are various organs such as the liver, the gallbladder, stomach, small and large intestines. Pancreas is somewhere here, spleen, kidneys at the back, urinary bladder, uterus, ovaries, etc. So there are a lot of organs here inside the abdominal cavity. Okay. Some are called hollow organs, meaning there's a tube, there's a channel. Examples are the intestines and the stomach. And some are so-called solid organs in which there's no tube. Examples are the liver, the spleen, the kidney. So abdominal disorder is a disorder of the abdomen. So it is therefore a definite disruption to normal or regular bodily structure and function of the belly. When you say belly, it's inclusive of the abdominal wall and the organs inside the cavity. But the specific cause is not yet determined. Thus, an abdominal disorder will include the following: disorder of the wall, the organ systems, and tissues within the cavity, such as the liver, gallbladder, stomach, small and large intestine, spleen, pancreas, kidneys, uterus, and ovaries. Once the specific cause of the abdominal disorder is identified, then a diagnosis of a disease is given. Example, in the abdominal wall, the specific disease or a specific medical condition will be a hernia or a cancer of the soft tissue part of the wall, the soft tissue, so-called soft tissue sarcoma. In the liver, examples will be liver cancer or hepatoma and cirrhosis. In the gallbladder, you can have gallbladder stones or cholecystitis, inflammation of the gallbladder. In the stomach, you can have gastric ulcer, gastric cancer as an example of a disease. Small and large intestines, You can have enteritis, which means inflammation of the intestines, or you can have cancer of the small and large intestines, which constitute the disease. Spleen, you can have hematological splenomegaly, meaning enlargement of the spleen due to blood problems. And then rarely you can have cancer of the spleen also. For pancreas, examples will be the pancreatitis, inflammation of the pancreas, and pancreatic cancer. And then for the kidney, you can have kidney stones or kidney cancer. And then for the uterus, ovaries, you can have myoma and ovarian cancers. So these are examples of diseases that can occur in the various disorder of this abdominal wall and the organs within the abdominal cavity. So the second topic will be what are the different types of abdominal disorders? So the different types are abdominal pain, abdominal mass, obstruction, bleeding, and jaundice. As I said, these are disorders with various specific causes which are not yet specifically identified, which are not identified at the moment. So this is just for discussions. When you say abdominal pain, it's the same as sakit ng tiyan, abdominal mass, bukol sa tiyan, abdominal obstruction, parado sa bituka or tubo, if there's any tube sa tiyan, abdominal bleeding, dugo sa or galing sa tiyan, jaundice, paninilaw ng mata na apektado ang atay, usually. Okay. So as I said, these are the Tagalog terms for the various abdominal disorders. Okay. But again, no specific mention of the disease yet, but these are caused by a lot of diseases or cause of medical conditions. Now, the next topic is what are the causes now of the abdominal disorders? So on this column, we list down the disorders. Now, we will try to identify the causes for each disorder. So, let's start with abdominal pain, sakit ng tiyan. Okay. The sakit ng tiyan can be caused by big category of cause, which are trauma and non-trauma. Okay. For the non-traumatic causes, the pain can be caused by abdominal mass, okay, which is causing the pain, okay, and there are different types of abdominal masses which we will discuss later on. Then abdominal obstruction can also cause the pain. Abdominal bleeding, there can be pain or no pain, okay, but in some instances there is an associated pain with bleeding. And then jaundice, again, it can be associated with pain. Abdominal mass or bukol sa tiyan, as illustrated here. So this mass is quite big that has become evident even from the outside, just looking. Okay. And then another example is a mass here on the abdomen. Okay. If the mass is small, it won't be visible on the surface of the skin. So abdominal mass or bukol can originate from the belly or the abdominal wall. It can originate from the abdominal wall and organs within the abdominal cavity. Okay. And the general causes are cancers and non-cancers. Abscess can also present as a mass on the abdomen. Okay. Abdominal obstruction or barado or bituka sa bituka or tubo sa tiyan. Okay. So when you say abdominal obstruction, usually it implies that there is a tube, a hollow organ, okay, like the stomach, small intestine, large intestines, hepatobiliary tree like the gallbladder and the common bile duct, and the ureters channeling urine from the kidneys. So these are tubes or hollow organs, okay, which channel foods and fluids to certain areas. So this can be obstructed. Okay. Examples of obstruction in the large intestine. So this is a dye, okay, drunk by the patient, and then it shows that it flows down from the stomach, it flows down to the small intestine, okay, and then to the large intestine, or yeah, most likely this is a large intestine, and then there is a cut off here. So there is an obstruction here, which hindered the flow of the dye further downwards. Okay, so the stomach, in the stomach, there could be obstruction, the small intestine obstruction, large intestine obstruction, because these are hollow organs. Another example of obstruction in a hollow organ or a tube, this time the hepatobiliary tree. So you can, example here will be stones causing obstruction of the gallbladder. Okay, so the stone has been in blocking the so-called cystic duct, that goes into the common bile duct. Okay, the common bile duct usually channel bile from the liver downwards. Okay, so if there is a stone in the common bile duct, it can block this tube, causing jaundice. Usually it will cause jaundice. Another example, the ureter, channeling urine from the kidneys, okay, showing the block here. So there'll be backflow or enlargement, dilatation of the proximal or the upper part of the ureter as far back to the kidney. So the obstruction can be caused by these cancers and non-cancers. So when you say non-cancers, these are the benign tumors. Okay, if it's not tumors, adhesions can also cause obstruction, intussusception, and abscess. So these are the more common causes of non-cancer obstructions. So tumors causing intestinal obstruction is illustrated here. So there's a tumor here in the so-called sigmoid colon, okay, the distal part, the lower part of the large intestine. Okay, so there's a small channel here left for food, for the feces to pass through. The moment this becomes completely obliterated, the part, the upper part, the so-called proximal part or upper part, will be dilated, okay, will be bloated, okay. So as a manifestation of intestinal obstruction. Adhesions usually occur if there is an operation done on the abdomen, okay. So you can all have these adhesions, and it can cause obstructions, okay. Intussusception is another example of intestinal obstruction, in which a part of the intestine telescope into the more distal part or the lower part, and then causing the obstruction. Okay. Abdominal bleeding, dugo sa o galing sa tiyan. This can come from the abdominal wall and the organs within the abdominal cavity. General causes, again, would be trauma, trauma to the abdominal wall and also to the internal organs can cause bleeding. Non-trauma, so the bigger categories of causes under non-trauma are the cancers and non-cancers. So non-cancers, you have benign tumors, you have the ulcers, you have hemorrhoids, and infection. Infection can also cause bleeding from the gastrointestinal tract. When we talk of gastrointestinal bleeding, gastro means stomach, intestine can be the small and large intestine. So when you say gastrointestinal bleeding, it originates from the gastrointestinal tract. Okay. And we usually classify gastrointestinal bleeding into upper GI bleeding and lower GI bleeding. When you say upper GI bleeding, the bleeding is coming from the upper part of the gastrointestinal tract, usually from the stomach and the uppermost part of the small intestine, which we call duodenum. Now, the lower GI bleeding, usually it comes from the lower part, which includes the rectum, okay, the lowest, or even the anus, the colon, the large bowel, small intestine, ileum, and jejunum. Upper and lower gastrointestinal bleeding. Jaundice, paninilaw sa mata, okay, which usually implies that there is affectation of the liver. Okay, so this the different causes are liver disease and biliary tree diseases. When you say biliary tree, it includes the gallbladder and the common bile duct, or the ducts channeling bile from the liver. Okay, and the general causes again are cancers and non-cancers, tumor. Okay, and then for the non-tumor entity, we have cirrhosis and stones. Stones can also cause jaundice. The fourth topic will be how common are the abdominal disorders. All are common, but the most common, I suppose, will be the abdominal pain, because abdominal mass can cause pain, obstruction can cause pain, abdominal bleeding can cause pain, jaundice can also cause pain. Okay, so in the end, if you were to be asked what is the most common abdominal disorder, it's still abdominal pain. But these four are also relatively common in the community. The next topic will be on clinical diagnosis of abdominal disorder. So here are some tips on how to do the clinical diagnosis. Okay. Number one, start with identifying the disorder based on the symptoms and sign. So you conclude with, based on the symptoms, is this abdominal pain, abdominal mass, abdominal obstruction, abdominal bleeding, or jaundice. Okay. So after identifying the disorder, then you proceed to analyze for the specific cause. Because pain can be caused by a lot of things, mass can be caused by a lot of things, obstruction by a lot of things, bleeding also, jaundice also. So we have to investigate or evaluate further to determine the more specific cause. So to identify the more specific cause, we have to use pattern recognition of a particular disease. So we have to know how a particular disease presents in a particular patient in terms of symptom and sign. And then if there are similar presentations of symptom and sign for 2 or 3 diseases, we choose the one, the most common, and then that will be your suspect or diagnosis. And what we're using is the so-called prevalence, okay, process. So you use the prevalence process in those patients, in those people with similar presentations of symptoms and signs. The other tips are, the basic evaluation methods consist of the following. When you do history taking, or you have to do history taking, meaning interview, try to ask the patient how she feels and what were the what do you call that? How she felt before the onset of the problem. Okay, so you're trying to get symptoms. Okay, and then doing a physical examination, usually done by physicians, but you can also do it. Okay, and because physical examination can be done on your own self or by another guy or a doctor. Okay, when you do physical examination, you're trying to get signs. Okay. So then after getting symptoms and signs, we combine, we process, and then we formulate a clinical diagnosis, which is a conclusion. As much as possible, we try to get down to the more specific disease causing the disorder. So the basic data that one has to get in the history when the initial symptoms were noted. Example, if you have abdominal pain, when was it first noted? Okay, and then let's say 1 week, 1 day, 2 days, okay, and then subsequent course. Is it more painful now? Okay, is it subsiding? Okay, is it increasing in intensity? Okay, and then the other data that you have datum that you have to get in the history is what are the associated symptoms. Okay, meaning example will be there's pain, is there associated vomiting, is there associated fever, okay, etc., etc. Now for the examination, the basic data is we have to look and palpate, okay, to feel the abdomen. Look and palpate, okay. Look for a bulge. In the earlier examples that I gave pictures, you can clearly see a bulge which will suggest a mass, okay, because the mass was already big to be seen on the surface. Then also look for distension of the abdomen, enlargement of the abdomen, palpate for a mass, okay, and then palpate for tenderness. So these are the 4 basic data needed in the examination to try to get to the more specific cause of the disorder. So when you do the examination, you look and palpate. You look for unusual bulge that may suggest a mass or buccal. You look for abdominal distension, meaning enlargement of the abdomen, which may suggest intestinal obstruction, or a big mass if it's present to cause the distension, or sometimes fluid, okay, abnormal collection of fluid. Palpate for possible presence of mass. If there is, then pursue that. That will be your cue that you're dealing with an abdominal mass, and then try to see where it's coming from. Then lastly, palpate for the presence of tenderness or pain. When you say tenderness, it's pain on pressure, okay? And if present, try to localize it, okay, the tenderness, and try to determine the severity of the pain, as these are important cues for the clinical diagnosis of a specific disorder. So as I said, example will be look for unusual bulge, okay, which may suggest a mass. Look for distension, which may suggest obstruction, a mass, or a fluid, okay. And then palpate for the presence of a mass, and also palpate for the presence of tenderness. For the abdominal pain, a tip here to try to evaluate or to analyze it and assess the patient with abdominal pain, first thing to do is to use the location to help you to localize or to suspect the possible organs of origin. Okay. So various locations with medical terms here: epigastric region, meaning on the upper part of the belly. Okay. By the way, when you say abdomen, it's not the stomach per se, it's the belly. The stomach is just one of the organs inside the belly. Okay. So epigastric region is in this area above the navel. Okay. Periumbilical region means around the navel, and then pelvic region is below the navel, pelvic. Okay. So if you have a mass here, a pain, we're talking about pain. If you have pain here, you start thinking of organs in this area that might be causing the pain. If you have pain in this area, there might be, let's say, the small intestines is usually in that area, small intestines or large intestine. It might be the source of the pain. For epigastric, in the epigastric region, if you have pain there, so you think of the epigastric regions here. Okay, you think of the stomach and possibly a part of the liver can also cause pain in this region. The other way of classifying the location of the abdomen will be to use the right upper quadrant, divide it into 4 quadrants, right upper quadrants, right lower quadrant, left upper, left lower. Okay, so this is a simpler way of classifying of the locations. Okay, so if you have pain on the right lower quadrant, okay, one of the suspect here will be your appendicitis because it's in this area. Okay. If you have pain in the upper right quadrant, you suspect the liver or the gallbladder. Okay. Then on the left side, if you have pain in the area, you start thinking of the spleen and part of the stomach or even the large bowel, large intestine. In the lower part, you can start thinking of organs in this area, the intestines usually. In the lower part, then you start thinking, if it's a female, you start thinking of the uterus, the ovaries. So when you have an abdominal pain, you ask and use the nature of the pain to suspect the possible organ of concern. Basically, as I said, there are 2 types of organs inside the abdomen, hollow or solid, and solid organs. Okay, so first, try to determine the nature of the pain. Okay. There are a lot of description of the pain. It's so difficult to analyze the pain in terms of description, in terms of terminology, but let me simplify it by saying, just determine whether the pain is crampy or not. This is the simplest. If it's crampy means parang humihilab, gano'n, okay? So if it's crampy, usually hollow organs are involved, like the gallbladder. If it's on this side, on the right side, the gallbladder is involved. If it's on the right middle part, stomach, and then lower part, if it's crampy, periumbilical area, then you think of the small intestine. Okay? So if it's not crampy, dull, tinutusok, no? Okay. Then you think of the solid organs. Okay, solid organs. Okay. Then when it's not crampy, the other entity, the other condition to think about is peritonitis, meaning inflammation of the lining of the wall. Lining of the wall. No? Okay. So if you have inflammation of the lining of the wall in this area because of acute appendicitis, which initially is crampy, and then once it has the inflammation has gone out of the appendix, you can have involvement of the wall, then you will have steady pain. So it's not crampy. Then you think of acute appendicitis. Abdominal mass. Again, you use the location to suspect the possible organs of origin. So if you have a mass here, you think of liver or gallbladder. You have a mass here, you think of stomach. You have a mass here, you think of the intestine, okay, etc. Obstruction. The cues for gastrointestinal obstruction, okay, will be the following: abdominal pain, because it's usually crampy, okay, vomiting, because the food cannot go in, okay. Then abdominal distension, because the food cannot pass through to a certain area. The proximal part or the upper part will be distended. And then no bowel movement. So because we expect every person should have bowel movement. If there's obstruction somewhere, there will be no movement of the feces downwards. Okay. So these are the 4 cardinal cues for gastrointestinal obstruction: abdominal pain, vomiting, abdominal distension, and no bowel movement. If 4 of these are present, more or less 99% you're dealing with obstruction. But sometimes you just have abdominal pain, just the starting of the obstruction, no vomiting yet, no distension yet, no bowel movement. Okay, but you have to include, you have to suspect gastrointestinal obstruction, even though you just have 1 symptoms. Okay. So in patients with suspected gastrointestinal obstruction, try palpate the abdomen for a mass, okay, as a possible cause and location of the obstruction. So if you feel a mass here, okay, so it's a possible cause for obstruction. And then when you localize it, it's most likely at the large bowel or the right side of the colon, the large bowel. So the first thing that you do when you suspect gastrointestinal obstructions to palpate the abdomen and look for a mass. If there is no mass, then consider, although the mass might be very small, but consider the other considerations that you have to make will be, is it due to adhesions? If the patient has a history of abdominal operations and there's no mass, then you think of possible adhesions causing the obstruction. Then the other cues that you can use will be the color of the vomitus, yung mga sinusuka, okay, as a cue for the site, as the level of the obstruction. Usually, if the vomitus is green and yellow, it's usually below the stomach, okay, because the bile usually comes in at this level, okay, duodenum, okay. So if you have obstruction here at the stomach level, usually the bile is not included here, it's excluded. So the vomitus here will be non-yellow, baka puti, no? Puti, or whatever you swallowed, you ate, will be the one that will come out through your mouth, okay. So if you have that situation, then you think of the so-called upper gut obstruction at the level of the stomach and above. Once you have yellow vomitus, because let's say the obstruction is at the level of the small intestine, the bile has already gone into the small intestine, and then when you vomit them, it will be green. So that's the cue, okay, using the color of the vomitus. Bleeding. The cues that you're dealing with bleeding is, of course, when you have vomiting of frank blood, red blood, passage of frank blood per anus, okay, red blood, okay, then black stools per anus, sa puwet, okay. So again, if you have bleeding, the first thing to do is palpate for a mass as a possible cause. If no mass, then you cannot entirely rule out the presence of a mass. It could be very small, okay, but just to say, you continue on to evaluate. So use the color of the vomitus and the stools, okay. So as I said, when you have frank blood with the vomiting and black stools per anus, then you think of upper GI bleeding. Okay, when you say upper GI bleeding, it's usually coming from the stomach and up to this duodenum area, okay. So why is it black? Because the blood here, when it goes down all the way up to the puwet, to the anus, okay, it will be converted by the enzymes into a black. From red, magiging black na yan, na? Okay. So, but if you have frank blood coming out through the anus, dito, usually the bleeding is down here. Okay. So that's importance of the significance, importance of the color of the vomitus of stools in terms of whether it's black or red blood. Okay. Jaundice. The cue for that somebody has jaundice is that there's a yellowing of the eyes. That's the easiest. Okay. Sometimes you can also have yellowing of the skin, but it's not very reliable. Okay. So you look at the white part of the eyes, and then if you have yellowing, you suspect jaundice. Okay. So again, when you have jaundice, palpate for a mass in the liver. Okay. When you talk about jaundice, we usually suspect something might be wrong with the liver. So we palpate in the liver area, the right upper quadrant, for a possible mass. If there is no mass, then you look for symptoms suggestive of hepatitis, gallbladder disease, usually with stones in the biliary tree causing obstruction, and pancreatic disease is another condition that might be causing jaundice. Paraclinical diagnostic procedures for abdominal disorders. The common Instrumental and laboratory diagnostic procedure for abdominal disorders will be the following. Imaging procedures, example, will be X-ray, either plain or with dye, the so-called barium dye, and then ultrasound, CT scan, MRI, PET scan, etc. I will not discuss this in detail now. I will just mention what are the imaging procedures, okay, that can be done. When I go to the more specific diseases next week, okay, I will discuss this more in details. Endoscopy. Endoscopy meaning you use a scope. So when you use a scope, usually you are trying to evaluate or study something that can allow the insertion of a scope. So it must be a hollow organ. Okay. So when you talk about upper endoscopy, you're talking about esophagogastroscopy. Okay. Scope to evaluate the esophagus and scope to evaluate the stomach, gastrostomach. Okay. Lower endoscopy, okay, lower part of the intestine, colonoscopy for the colon, the whole colon, sigmoidoscopy, the lower part of the large bowel, and proctoscopy is the anorectal, the lowest part of the colon. Okay. Then, of course, you can have various blood tests. Example will be CBC to check the level of the blood, hemoglobin, okay, whether there is active bleeding or not. Liver function test, okay, to check the enzymes coming from the liver, which might give you some clue on as to cirrhosis. Hepatitis also, profile, tumor markers, possible cancers, okay. A word about the use of paraclinical diagnostic procedures, okay. General rules will be, it will be dependent on the competencies of the physician managing the abdominal disorders. Okay. We expect competencies from the physicians, but have a knowledge on this so that you will be empowered also to question or to ask why this, why that. Okay. So the physician should know the uses and indications of all known instrumental and laboratory diagnostic procedures for abdominal disorders. Okay. So just for yourself, get a general knowledge, the fundamentals and generalities on the uses and indications. Then the physician should be using it, all the diagnostic procedures only when needed and indicated. Okay. And then as mentioned before, to know which one is needed, you come out with a BRCA, the benefit risk cost analysis process. Okay. Analyzing the various options and then try to select the most cost-effective one. And after the paraclinical diagnostic procedures has been done, the physician should know how to interpret the results. Okay. So this is the BRCA process that I've been teaching you all this while. Okay. So on the first column, list down all the options, and then what are the comparative benefit of all the three options. Okay. Your goal is to be more definite on the diagnosis of the suspected condition, then the risk, the cost, then availability, whether the paraclinical diagnostic procedure is readily available in the community. Basic treatment modality, this is the last topic. So here on the first column are listed the 5 disorders that we were talking about, and then with this, in each of the disorders, you can have specific causes, so many, and then so the physician will have to come out with a decision. The general decision is in terms of treatment, whether it's surgical or non-surgical. Okay, so the definition of surgical here or non-surgical will be the following. Surgical means the disease needs an outright surgical intervention or operation. Non-surgical, it's a medical disease that do not need surgical intervention, no operations. Potentially surgical, it's not surgical, but it should be done only when needed. So example, if you have abdominal pain caused by a ruptured appendicitis, then it's outright surgical. So you have to operate on the patient as soon as possible. For non-surgical, at all times, you have hepatitis. Now, it's a non-surgical condition causing jaundice. Then, no need for surgery. Okay? Although jaundice is part of the disorder here. Potentially surgical, example here, you have gallbladder stone, which is not causing any symptoms, no problems. You don't have to undergo the operation first. You just observe, wait and see. Then if there is a undue development that will happen, then let's say you experience extreme pain, then you go for surgery. So that's what is meant by potentially surgical. Okay. So these are the three situations that might exist in terms of the treatment modalities. Okay. Okay, I already explained this, but let me repeat. Okay, examples of surgical abdomen, outright indications for operations, peritonitis most of the time. Okay, then operable cancer. If it's not operable, then it could be non-surgical. Okay, and then peritonitis sometimes can, with some exceptions, it can be non-surgical also, just using antibiotics. Okay. And then obstruction by the tumor, usually surgical, okay? Then tumor bleeding, usually surgical, okay? If it's bleeding from an ulcer, sometimes you can do non-surgical treatment, okay? Giving medicine. Then obstructive jaundice, if you have a stone causing blockade of the passage of the bile into the intestine, okay? Then outrightly, it's a surgical condition. So that's the reason for calling it a surgical abdomen. So this is the BRCA process in selecting the cost-effective treatment modalities. Earlier, I projected the slide on BRCA on selecting the most cost-effective paraclinical diagnostic procedure, but this time it's the treatment. So you list down the various options, okay? In terms of surgical treatment, and then the goal, the risk, the cost, availability. Okay. So, summary and takeaway, I have presented the following. Okay. I will not read them anymore. Just take a look, quick look. And then, takeaway in relation to the patient empowerment. Be always in touch with reliable medical information on the fundamentals and generalities in the medical management of abdominal disorders. I don't expect you to be an expert on all the information here. Even doctors are not completely knowledgeable of all the medical information, but at least just try to get the fundamentals and generalities. That will be sufficient. Okay. Knowledge is power. It gives power. Use the 4 Ks of patient empowerment: kaalaman, kakayanan, karapatan, and kapangyarihan to gain greater control over decisions in the medical management of abdominal disorders in case you have one, your relatives have one, and other people that you want to help. Okay. So with that, I end my pep talk. I hope I have empowered you to have a better understanding of the fundamentals and generalities in the medical management of abdominal disorders. As I said, this is just an overview. Okay, we will discuss the specific conditions in the subsequent pep talk. So before we go to the question and answer portion, as a reminder, please take the OLETE for Mastery of Learning and have a perfect score to get a certificate. The link is already in the chat box. I saw it. Okay. 50 OLETE certificates will entitle one to a voucher for ROJoson telemedical consultation. So let's now have a group picture taking. Show your face, beautiful face. Okay. Some are shy to show their face. Okay lang. 1, 2, 1, 2. Oh, yeah, habol. Okay. Okay. Siya na lang, si Delete. O, sige. 1, 2, 1, 2, 3. Oh, may umabol si Delete. Okay. The floor is now open for questions, comments, anything that you want to share. Whether Ed? Okay. Based on your personal experience in the past, with yourself, with your relatives. Okay. I suppose all of us have at one time experienced abdominal disorder. Tama? Okay. We cannot really escape it. No? Any question?
Doc, experience ko po, Doc.
No, si Jen.
Yung pong mother ko na namatay, death anniversary po niya ngayon.
Okay.
Diyan po, Doc, umpisa, yung nagkaroon po siya ng pain sa tiyan. Tapos po, nagsusuka siya. Hindi po siya masyadong nakakadumi. Dok, ano po siya lumaki po ang tiyan ng nanay ko.
Okay.
Hindi po namin alam kung saan nanggaling. Pero nung pina-check up po namin siya, doon po namin nalaman na meron siyang ovarian cancer, stage 3C po.
Okay. So,
saan po kaya nanggaling yung, bago po kasi siya namin mapa-opera, kasi nga po, lumaki po ang tiyan niya ng halos parang buntis ng 5 months. Pinatanggal po muna nung doktor yung tubig po sa tiyan.
yung tubig sa tiyan. And then,
Opo.
and then,
Nahirapan po po. Yun po, hindi po siya pwede munang operahan sa ovary na tanggalin hanggat hindi po natatanggal yung tubig niya sa tiyan.
okay. Okay, how do I answer that? Okay, your mother has symptoms. Yung symptoms na i-apply ko lang yung ni-lecture ko, no? So, may abdominal pain, may vomiting, may distension,
No bowel movement po.
No
yung
bowel.
Intestinal obstruction po.
Ang presentation yon is parang obstruction, okay? Intestinal obstruction. And then, ang next step to evaluate is ano yung nagko-cause ng obstruction, no? Okay? So, can be tumor, as I said, tumor or non-tumors, no? Okay? So, may nakitang ovarian cancer, okay?
Opo.
The ovarian cancer, unless kumisan, baka walang ovarian cancer, medyo malayo sa bituka, di ba? Medyo nakahiwalay, di ba? Okay? So, pero kumisan, they can present like may barado sa bituka, no? Okay? So, yung paglalaki ng tiyan niya is caused not by the yung nag-distend ng intestine, lumaki intestine, but by the fluid. By the fluid. Kaya lumaki ang tiyan niya. No? Ascites ang tawag doon. No? Okay? Okay. So, the vomiting, baka vomiting, baka because of baka effect ng cancer na yon, no? Pangit ng pakiramdam niya, no? Laging mabigat ang tiyan niya, kaya nagba-vomit siya. Okay? Yung pain could be caused by the pain of the ovary, no? Yung cancer of the ovary. Masakit. No? Okay? Yung no bowel movement, walang bowel, bakit hindi siya nakakadumi? Kung hindi siya talagang nakakadumi, kung barado, then baka yung cancer niya sa ovary, baka nakapatong na dun sa intestine. Baka iniipit na. Baka. Okay? Pwede rin mangyari.
Opo, medyo late na din po kasi namin nalaman na gano'n na po yung late na po namin na napa-check up, tapos nung mapa-check up namin, yun na po agad yung findings po ng doktor.
Okay, so ang tanong niyan, kung anong ang naka-focus na yon, yung ovarian cancer, kung anong gagawin doon. Yan ang gamutan na, no? Okay. From abdominal disorder, more specific cause, ovarian cancer. Okay? So, ang treatment noon, naka-zero in na doon sa sa specific disease. Yan ang specific disease, no? Ovarian cancer. Okay? So, you determine the extent, no? Yung stage, di ba? Okay? Kung far advanced na, yung lecture natin dun sa breast cancer in the past lectures, we said, depending on the stage, baka palliative na or curative. No? Kung palliative, for example, din sa mami mo, may tubig na sa tiyan, no?
Yes.
Advanced yan, kaya tubig lang tinanggal. No? Okay?
Opo.
Okay. So, thank you for that sharing so that we can apply yung mga ni-lecture ko dito. Na? Okay.
Ay po.
Thank you.
Thank you po.
Any other question?
Yeah, there is another question from Melingo. Tumor markers are accurate. Is tumor marker accurate? And there is also a question, follow-up question from her. Is frequent farting a sign of abdominal issues?
Frequent,
Farting. Utot. In Tagalog.
Frequent farting. Abdominal issue. Okay. Okay, let me answer first the first question. Tumor markers, are tumor markers accurate? Ang tanong niya. Okay. Tumor markers can be accurate, can be inaccurate. Okay. Basta tandaan niyo, in medicine, lahat, no? There's no such thing as 100% accurate or perfect. Okay. So, wala. No? Just like yung person natin, we're not perfect, di ba? Okay. So the doctor will have to evaluate, no, and check whether yung value should be acceptable. Okay. And to check whether the value should be acceptable, ibabangga dun sa symptoms, yung pasyente mismo, titingnan niya yung mga symptoms and signs. So that's why palaging may clinical diagnosis and then in laboratory, ibabangga. Kung nagtutugma siya, tanggapin yung tumor markers, yung laboratory test. Kung hindi siya nagtutugma, the doctors will have to make a decision. Uulitin ba yung markers? Or hindi na, baka itabi na lang niya, and then use other tests. No? Okay? So tandaan lang ninyo, basta when anything, laboratory-wise, physical exam-wise, no such thing as 100% perfect. That's why the doctor will have to scrutinize, keep on evaluating, and assess, and then make a decision whether to accept or not to accept. Okay. Follow-up questions is frequent farting is a sign of abdominal. Well, hindi ko alam kung ano. Farting is utot, di ba? Utot. Okay. Utot ng utot, frequent farting. It could be, yeah. And when you say abdominal issue, yeah, it could be an abdominal issue kasi nanggagaling sa intestine yan eh. Yung utot, di ba? Yung utot galing sa intestine. So, since the intestine is part of the abdomen, it's an abdominal issue. Okay, so I don't know what Melly meant by abdominal issue. Is it something? Is it what is the cause? Baka gusto niya tanungin what is the usual cause? Then is it something that we have to be alarmed with? No, okay. So kung if you can, kung may ano ba yung mga parting lumalabas, ang hangin, di ba? Ang mas between no farting and with frequent farting, mas gusto ko may farting. Okay? Kasi kung walang farting, barado. Baka barado yung tiyan mo. Okay? So remember the cues for intestinal obstruction, no bowel movement. No bowel movement is one of them. Pero yan ang late stage na. No? So before you reach the no bowel movement, kumisan may konti-konti pa lumalabas. No? Okay? May konti-konti pang tae lumalabas, baka partial pa lang yan, hindi pa complete. No? Okay? Or, yung mga utot, kumisan tinatanong namin sa pasyente, umuutot pa ba yung pasyente mo? No? Okay? Pag sinabing umuutot, mas maganda yon. Okay? Okay? So, hindi pa complete. Pag wala ng utot, no? Baradong-barado na yun. No? Okay? So, yung anong frequent cause of farting, basically pagkain lang yan. Na? I suppose it's pagkain, na? Because of the digestion of the foods. So you just try to monitor the foods that you're eating. If it's causing frequent farting, avoid mo na lang. Avoid mo na lang. Minsan, hindi mo avoid, sabihin mo na lang, sorry, no? Pagtyagaan na lang nitong utot ko, tangkapin na lang ninyo. Kung mabaho, kumisan baka mabango pa. Okay. Next question.
Meron daw from Chris Nisea, meron daw pamamanhid sa upper right side on and off. What is it?
Right side of the abdomen?
Upper right side.
Upper right side of the abdomen. We're talking about the abdomen. Right?
Most probably.
Chris, alika, i-amplify mo na lang para masagot kita ng mas maigi.
Hello, Doc. Good afternoon.
Saan? Right upper right side of the abdomen?
Upper right side of the abdomen.
Okay.
On and off, Doc, na mamanhid. Sa posible ba na sa pag-upo lang yon? Kasi pag working ka, medyo naiipit or meron dapat i-observe.
Yeah, you observe mo. All the symptoms that we have in our body, always observe palagi. Okay? No matter what. Basta you observe niyo over time. No? Now, kung namamanhid, i-check mo na lang kasi na-localize mo right upper quadrant sa abdomen. Di ba? Parang may symptoms ka sa right upper. No? So, unang gagawin mo, titingnan mo yung balat on the surface kung merong mga abnormality. Okay? Kung wala naman, then kapain mo. No? Kapain mo. Kung meron kang nakakapangbukol or anything unusual. Okay? So, kasi kung baka may makapakang bukol, no? That's it. No? Baka that would explain yung pagpamanhid mo. No? Baka may liver tumor, gano'n. No? Okay? O kaya baka may nakapaka dyan, parang may bukol, baka nasa balat. We took this up last time, soft tissue tumor, di ba? Soft tissue tumor. Baka may tumor of the nerve sa tiyan. Sa wall lang yan, sa wall, ha? Hindi sa loob, no? So it all depends, no? So as I said, I would teach you, number one is to before the monitoring, no? The observation, do something, look and palpate. Okay? So tingnan mo muna kung merong abnormality on the surface of the skin. Kamisan baka may shingles siya. Pwede rin, papamanhid, no? O kaya no? Or look, palpate for a abnormality kung meron siyang bukol or something unusual on the abdominal wall, sa right side, or deeper sa loob, baka sa liver o sa intestine. Na? Kung wala naman, then try to see is it a problem of baka yung sinasabi mong ergonomics, na? Okay, palaging nakaupo, na? Okay. Palaging nakayuko, na? Then try to change yung habit and see if it will go away. So kasama na yung observation doon. Okay? So thank you for that question. So I hope I have
Thank you po, Doc.
amplify the answer in terms of application, what I've been teaching you from the very start. No? Okay.
I have a question, Doctor. What is an abdominal aneurysm? And what causes aneurysm of the abdomen?
Aneurysm, by the word aneurysm, it implies the blood vessel abnormality. No? Blood vessel. No? You can have aneurysm sa brain, you can have aneurysm sa eyes, in every part of the body pwede, as long as there is a blood vessel. So abdominal aneurysm, usually abnormality of the blood vessels, usually sa aorta. Yung sa aorta, yung malaking blood vessels sa tiyan. No? Okay. So lumalaki, yung parang yung wall, yung blood vessel, there's a wall there. Kung mahina ang wall, magdadilate yon, no? Okay? Ibibigay, no? Parang varicose veins, no? Varicose veins vein, yung aneurysm usually yung mga artery, no? Sa varicose veins, pag lumalambot yung mga elasticity ng mga ugat mo, magbabalon yan, kaya lumolobo, no? Okay? So abdominal aneurysm, usually aorta, and then yung wall niya lumalaki, mahina, okay? To the point na kumisan, baka pwedeng pumutok. No? Okay? It might be due to age factor. It may be due to hypertension, other, okay? Any more? Meron pa.
Yeah, hepatitis from Sinaido Cabral. Is hepatitis B nakakahawa po ba?
Hepatitis, yeah. Hepatitis nakakahawa talaga. Okay. So just try to avoid it. Okay. Yung mga pasyente may jaundice, no? Try to stay away from them. Okay. Ano pa? What is the pylorus? Okay. What is the pylorus? Ito drawing ka lang, ha? Ito drawing ka lang. Nakita yung whiteboard ko? Nakita niyo yung whiteboard?
Yes, Doc.
Yes, Doc, kita po.
Yes po.
So this is the stomach. Maraming parte yun. May mga parts na tawag dyan. Cardia. And then this is the so-called body. And then here, antrum. Antrum. And then here, pylorus. Saan? Banda rito, you call that pylorus. Okay? Any follow-up questions?
Doc, is there a shield or something that opens between the stomach and wherever the
wala talagang what do you call that? Wala yung talagang
door.
walang door, but there's may mga sphincter diyan, may mga sphincter, no? Nagko-cord ano yan, nagko-contract, no? Okay. Okay, dito rin may mga sphincter din diyan, no? Okay. So, wala man talagang door na nag-block, nag-open or close, no? Okay. Okay, so food will come in from this esophagus, diba? Okay. So, pag nakapasok na, okay, kaya nga tayo hindi hindi bumabalik yung pagkain, no? Because of that sphincter, no? Okay, intact siya, nagtatrabaho siya, no? And then, dito sa stomach naman, bababa siya, di ba? Okay.
Mhm.
So magko-contract din siya every now and then. So pagdating dito, may mga sphincter din dyan. Na? Ganon. Na? Okay. So, not a complete na door or window that will block it. Na? Open and close. It's on the side. Na? Okay. Okay? Bakit mo natanong yung pylorus?
No, kasi my nephew, matanda na siya, no? Pero nung bata, nagkaroon siya ng condition that it took us years before nasabi nung doktor na it was his pylorus. Kasi nagpo-projectile vomiting siya eh. And he was only 10 years old.
Okay.
So, it happened every month for years. So, it happened every month. He could not eat anything. So, every month, nasa ospital kami, nagsuswero. Tapos mawawala. We went to so many doctors here ho. Una sabi, meron daw siyang epilepsy. Yung mga ganon. Then finally, we pulled our resources and they went, abroad, ganon. And then the doctor there said it was his pylorus. That apart something triggers the pylorus na hindi daw ho nagpro-proceed yung food to the large intestine because the pylorus it constricts.
Yeah.
So the food, talagang parang possessed yung napanood nyo yung yung Exorcist, talagang tumatalon ho talaga yung food. Talagang
Okay.
oo, talagang.
Okay. As I said there, yung sphincter lang naman yan eh. Na? Sphincter doon. Na? So there's such a thing as congenital abnormality doon. Masyadong malaki. Na? Okay. So yung congenital pyloric stenosis. Na? Ganon. Na? So ang gagawin lang naman doon, ihiwain lang yung muscle, i-release lang para lumuwag. Na?
Hindi na ginawa ko yun.
Yeah, but not really going inside yung sa loob. Yung wall lang, i-release para bumuka. Na? Okay? So usually wala ng problema. Pero usually sa bata pa yon. Let's say newborn, napupuna na yon. No?
He was not, bata pa siya, wala pa siyang 1 nun.
Wala pang 1 month. Ayun.
Wala pang 1 year old. 10 months lang siya.
Yun, congenital pyloric stenosis yun. No?
Pero unfortunately nga ho,
naoperahan siya?
Hindi ho, kasi nalaman ho nun, nasabi na lang when he was about 7.
Okay. So maswerte siya kasi depende sa depende sa degree of stenosis yung extreme, no? Yung pa maluwag-luwag lang, kaya walang masyadong symptoms, no? Okay.
Oo. Okay naman ho. I mean, pag nangyayari, alam na niya kung anong gagawin. Swero na lang, then pupunta. Pag umulit, he goes to the hospital. He's an adult na. He goes to the hospital na lang to gain and then it subsides. Okay.
So, yan ang sinasabi natin. Sa medicine, maraming condition that we cannot really explain. Iba-iba. No? Okay. So, thank you for sharing.
Ayun.
Okay.
Tapos one more, I'll share with you one more about waiting and observing. Many years ago, I suffered from pain. Sa right side ho. So it went on for months. Tapos finally the doctor ultrasound. Now suspected lang daw na gallbladder stones, pero they were not sure. So they wanted to open me up, but my mother said it's just suspected. Why will you open her up? Hindi pa kayo sigurado. So sabi ng mami ko, no. So we observed, and then ang ginawa na lang ho is I went on a liquid diet and then also olive oil in the morning for about a month. Nawala ho, and it just disappeared. Kung ano man yun, nawala na, and I've never had it again. Okay. So I thank my mom for not having me operated on.
No.
years later, of course, you get so many ultrasounds. Wala na ho. There was no suspected or whatever na shadow in the gallbladder or anything. Wala na. It just disappeared kung ano man yung shadow na yun. So it really...
Maswerte ka. Okay? So you thank your mom. You thank your mom.
Oh,
Okay. Basta,
yes.
okay. Pero tandaan nyo, there's such thing as wait and see. Wait and see. Ha? Okay? A lot of doctors do not believe in wait and see. They talagang hahanapan ka ng isang sakit, no?
Oo.
And
Oo.
then
Oo.
gagamot ka na with all the established procedures, no? There's such thing as wait and see. Okay? Then the other lesson is that you have to be very specific with your diagnosis, di ba? So kung may suspect lang, then you have to quantitate it, no? Okay.
Yes.
So is it 99%? Baka 10% lang. Then wag na lang, di ba? So you have to quantitate it in terms of try to challenge all your doctors. Is it 90% or 10%? No, ganon.
That's what my mom said.
Mga doctors usually they don't quantitate it, no? Ako I do quantitate it, no? Kasi lahat naman unsure di ba? Lahat ng diagnosis unsure, but you have to quantitate it. Is it 90% sure versus 10%, and then more or less guided ka na. If it's less than 90, and then that's time you do a lot of tests, di ba? Tests can be done. Okay. Among the tests will be wait and see then, kasama din doon, no? Ganon, no? So,
Kasi
sa tiyan, marami especially abdominal pain.
Yes.
A lot of times we cannot really explain unless talagang parang yung kay Jeng, no? Talagang malaking-malaki na, malalaman mo agad. But in the early stage of the tumor, in the early stage of the obstruction, mga symptoms ma-feel nyo are non-specific. Hindi siya, walang clear-cut picture. Walang clear-cut. So it's either you do the test or you observe. No? Okay? Watch and wait. No? Okay? When you say watch and wait, you should do it closely also. Close monitoring. No? Baka kasi kung minsan ayaw ng doktor ng watch and wait, kung watch and wait, kung namatay, sisihin pa ako ng pasyente, di ba? Okay? Okay?
Oo nga.
They use that as a reason. Ayaw nilang mag-watch and wait. But it's a matter of educating the person, no? Kaysa too aggressive palagi, no? Okay?
Yes.
Okay?
That's true.
Any more questions?
Yeah, from Ma'am Jackie. Would frequent burping be a cause for concern as indicative of a digestive issue?
Burping sa akin per se is not. No? Okay. Now, when you have burping, if it's associated with parang obstruction na of the stomach, at the level of the stomach, no? Then I would go for a endoscopy na. No? Ganon. No? Okay. But if just burping per se at nakakakain ka naman, tumutuloy yung mga pagkain mo, whatever you eat, no? Wag mo nang pansinin. Okay? I mean, don't put too much serious thought on that. No? Okay. So just observe and then try to adjust the food that you're eating. Kung minsan food lang yan yung mga pagkain. No? Adjust it lang. And then see it will disappear, or at least kung magle-lessen siya, okay lang. No? Kung if it's that, kasi kung minsan hindi natin ma-identify completely what's the food that's causing it, di ba? So as long as it's not increasing, ganun pa. When you say watch and wait palagi, you look for the monitor the symptoms, whether it's palaging persistent, hindi siya nawawala every hour, every day, no? And if it's increasing in frequency and intensity, no? The moment you have all those things, then that's time you really have to make a serious decision on to consult a physician already. No?
Okay, there is another question from Rochelle de la Cruz. Hi, Doc. Question po on abdominal bleeding. As you have shared, one of the symptoms is black stool. Ang abdominal bleeding po ba heals on its own or kailangan po talaga ng gamutan?
Okay. Abdominal bleeding can heal on its own if it's caused by something that can be reversed by itself. Na example, ulcer, na yung mga ganon. Enteritis, na inflammation, which can heal kamisahan even without medicine. You just adjust your diet. No, it can heal by itself. Then the bleeding will stop. Na, okay. Kaya kumisan watch and wait pa rin, di ba? Okay. Or if it's due, yung mga infection can also heal by itself. Mawawala yan in due time, di ba? Okay. So you don't need antibiotics, but sometimes you can give antibiotics to hasten the, basta ma-identify mo lang yung cause, no? Okay. But if it's the bleeding caused by the tumor, by a tumor, and then hindi siya, lalo na kung cancer, usually hindi siya mawawala. Even benign tumor, once established it's a tumor, kahit na benign, usually hindi siya nawawala. No? Okay. Did I answer your question, Rochelle?
Yes po, Doc. Marami pong salamat.
Wag mong
There is
isipin na-
another one from Belet del Rosario. Doc, what is the cause of GERD and how can it be treated?
Okay, can I beg your indulgence, Belet? We will discuss this some other time. Okay. This is a big issue for me also. No, okay. I will, kasi ang personal opinion ko, it's a parang overkill diagnosis yan eh. Na? Okay. I will make a paper out of it. Na? Wag mo na ngayon, ha? Okay.
Kasi ano yun ang problema ng anak ko? Yung GERD. Yun ho yung problem ng anak ko. Yun ho ang sakit ng anak ko, yung GERD na yun. Matagal na ho niyang ginagamot.
Yeah, nga. Ako personally, hindi ako sold sa mga outright GERD. Na?
Okay po. Sige po.
Baka I might come out with a position paper on that. Na?
Okay po.
Pero at the moment, ang sinasabi ko lang, GERD is actually ang feeling mo, nag-ano ka lang, nagbaburp ka, nag-regurgitate, di ba? Buwabalik yung mga pagkain mo, gano'n, no?
Okay, opo.
And then sometimes it can cause symptoms, maasim, gano'n, no?
Yes po.
At the moment, usually, a lot of times, kasi 5 or 10 years ago, wala naman kaming GERD na pangalan eh, no? Usually, sabi namin, ay, ano lang yan, nag-burp lang at nag-regurgitate, no? And after a few hours, wala na, di ba? Okay? I-adjust mo yung pagkain mo. And then, here comes, may nag-create na ng isang pangalan ng disease, GERD. Kaya lahat ng doktor, the moment you have symptoms, konting symptoms na, ay, mahirap ang maghinga, ganon, chest pain, GERD na yan.
O heartburn.
Heartburn, bibigyan ka na ng mga omeprazole. Yeah.
Oo, ito po yun.
Mahal.
Okay, yung iniinom. Omeprazole, pantoprazole.
Yun, mahal na yun. Okay. Okay. So, hintayin mo lang ako. Remind mo na lang ako na I will make a paper out of that. Na?
Okay, sige po. Thank you po, Doc.
Okay. Any more?
No
Wala na.
more.
Okay. So it's 3:27. No more questions. No. So we will call it a day. No. So we'll see. The next one will be abdominal pain. Most likely abdominal pain. We will use that order: abdominal pain, abdominal mass, abdominal bleeding, obstruction, and jaundice. No, i-develop ko yan. No. Okay. Then after that,
Thank you, Doc.
we put the GERD. Last part. Okay.
Thank
you. No more questions. Let's call it a day. Thank you for attending. Okay. I hope
Thank
you
you.
continue to attend to give me motivation to keep on working for you. Okay.
Thank you, Doc.
Bye-bye.
Thank you.
Bye. Bye-bye.
Bye.
Bye.
Thank you po.
Bye.
Thank you.
Thank you po, Doc.
Welcome. Okay. I'll turn this off now. Okay, bye-bye. I'll see you.